Welcome to today's webinar. Melissa is here somewhere, but we can't find her, and that's okay. What we're really trying to do is to share some information from two very insightful gentlemen on redesigning emergency medical systems for financial stability. We know that there are news articles every day, locally and nationally, on what's happening with EMS systems across the country. And these gentlemen bring a wealth of information as it relates to how systems are changing to become more economically sustainable. You will notice on this webinar that we have a Q&A panel. So we are committed to doing questions and answers from you all, because that's the most important part. We have some canned questions, tough ones, two questions that the panelists haven't seen yet. So we'll see how they handle those questions. I'm just kidding, gentlemen. Okay. So please, if you have questions, put them in the Q&A panel, and we will get to those at the end of the webinar. Handouts are also going to be put into the chat window, so you can download handouts from the things that are referenced during the webinar, plus some of the other webinar materials. And if you have any technical difficulties, please use the chat button to get hold of Melissa, and she'll try and help you with some of your technical difficulties. So I'm going to do a brief introduction and have the panelists tell you about themselves. We are very excited to have Dr. Doug Kupis with us. Doug is the president-elect for the National Association of EMS Physicians, a prolific researcher, and a generally nice guy, which is really unusual when you have EMS, I'm totally kidding, EMS physicians. Dr. Kupis, do you want to introduce yourself, and then we'll move to Tom?
Sure. Doug Kupis. I'm, as was said, an EMS and emergency physician in central Pennsylvania with Geisinger Health Systems, but very honored to be president-elect for NAEMSP. And I also am very honored to serve as the medical director for NAEMT.
Awesome. Thanks. And Tom, please introduce yourself.
Thanks, Matt. I'm Tom Wazurek. I'm the director for the Center for Public Safety Management located in Washington, D.C. We were created by the International City County Management Association and were turned into a standalone enterprise in 2014, so our 10th anniversary. But my background is in police, fire, city management, and executive director for the Commission on Fire Accreditation International.
Awesome, awesome. And my name is Matt. I'm going to be sort of the instigator for this webinar. It's actually instigator for actually doing this webinar. We're very excited again to have Dr. Kupis and Tom with us. I am currently the Chief Transformation Officer for MedStar Mobile Healthcare in Fort Worth, Texas. Also the South Central Regional Board Chair for NAEMT, and I also chair their EMS Economics Committee. And as of next week, I will be the Vice President for Page, Wolfberg, and Worth Advisory Group. So very excited about that and get to continue working with these two fabulous gentlemen as well, and helping to redesign EMS systems all across the country with PWWAG. So let's first talk about one of Dr. Kupis's and I think Tom's favorite topics, and that is the impact of response times in EMS delivery. We know that response time standards are really the highest cost driver for an EMS system, and financial stability is becoming a real issue. But Dr. Kupis, as an EMS physician, medical director, as we mentioned earlier, an amazing researcher, you did an extensive report for NHTSA and the industry, really the profession, on light and siren use, which included a lot of literature review on response times. What are your thoughts on response times in EMS system design and delivery?
Sure. Thank you, Matt. And certainly this has been my passion for my entire career. If you look at the research and things that I have done, response times, lights and siren use has been at the core of it. And it really started when I was a paramedic, and I still am a field responding paramedic. The issue, to sum it up, and I know we have a lot of people that are on this webinar that may represent more of the community side and community officials and that sort of thing. So to sum it up, we really have set up an unsustainable expectation that everybody that calls 911 should get care within 8 minutes or less, or some other number your community might use. And I think that the issue with that is it has never been centered around the care that all of the people that call 911 need. It has never been really patient-centric. It has been centered around one thing, and that's response to potential cardiac arrests. And so much has changed since that initial approach was taken, but we haven't changed the approach. And I think that, there are a lot of things we could say to sum that up, but clearly, studies have shown that probably less than 5% of the patients that EMS respond to are true emergencies that need something that they can do in a very time-sensitive way, where the time saved by lights and siren or quick response times matters. And we have ways of sorting those out. So, that's number one. And number two, we should be treating these things like it's a prescription. If somebody needs a rapid response and lights and siren use or just even a rapid response, those patients should get it. But the other ones should get what they need, the right thing to the right patient at the right time. And sometimes that's a whole different paradigm than what our current systems are established around.
Excellent. And from your extensive research or your thoughts on what you looked at recently, in terms of overall EMS response volume, what percentage of the typical EMS response volume represents those truly high acuity, potentially life-saving interventions being done by EMS as a percentage of overall response volume?
Sure. Well, a study by Dr. Jarvis looked at the actual care given to a large group of EMS responses and found about 7% of those had a care that needed a patient life-sustaining or life-threatening condition treatment. They used a very, very liberal definition of what those treatments were. So I think it is fair to say that it's probably, when you look at other details, less than 5% of those calls. And we realize in all of what we do with EMS that there has to be a balance between under and over triage. If we wanted to get to every single person with the utmost potential care, then we should clearly be going to everything with lights and siren, and we should have way more resources in every community that it could possibly have, because we wouldn't want anybody to have a delayed response. But the fact of the matter is, I think it's more appropriate to compare us to the emergency department. When people come in the front door of the emergency department, everybody that checks in doesn't get thrown onto a litter and rushed with people running down the hall to a resuscitation room. Some people have that happen, and when they are triaged, and then other people are, and the public knows this, are sent to the waiting room, and there's a wait period to be seen because the resources couldn't possibly send everybody down the hall to a big resuscitation room. I think we should be looking at EMS in that same way. And Mike or Matt, this is probably a good place to bring up. There was a multi-organizational, multi-association position statement that was written on lights and siren just a couple of years ago. It got a lot of fanfare. I've been writing and doing things related to lights and siren for 4 decades now, and the needle is moving. That position statement was one of the things where there's a palpable difference across the country, and people are starting to realize that we shouldn't be having that maximal response to everything. Happy to announce that there is a follow-up to that, where 15 organizations have just approved, and it's soon to be published, but it is available on some of the organization websites, another position statement that is the performance measures that communities should be looking at beyond just measuring lights and siren. And I think that, as we see more of these things come out, we're seeing more people start to focus and think about, well, are there other things that we should look at and not just how fast we get there to determine how our communities should prepare for this. And those alternatives are less costly.
Yeah, and Dr. Kupas, those 15 associations arguably are oftentimes 15 associations that can't normally agree on the color of the sky. But they
Yeah.
agree on
And you know, we there's a lot of talk about things that are either bipartisan or totally partisan these days. But I like to basically bring up this is this is a multi-partisan thing, because these 15 organizations represent EMS, but they also represent Tom's group, local governments, safety, quality, and fire. So, there are organizations from all of those disciplines that are represented here, and it really is very collaborative.
So, Tom, clinically, as you've heard Dr. Kupas talk about, only a very small percentage of the EMS response volume really needs that quick, life-threatening response, etc. From really just looking at it from a public policy perspective, how prevalent is it that communities rely on response time as the primary goal for an EMS system, and how is that changing in your view? You do a lot of consulting for communities all across the country. How are local governments beginning to really look at that now differently, perhaps based on the evidence and the research that's being published and that CPSM is used in a lot of their reports?
Well, a few things. One, if you're just looking at how fast the unit gets there, you're ignoring a whole kind of landscape of other issues that go into when do you get to the patient side. First one is your dispatch center. Are you monitoring how long it takes to answer the phone? How long it takes to begin to get and capture the information? One of the challenges that we've started to see is a number of communities are starting to engage AI in their dispatch center. And what we've started to see in some cases, if no one is kind of watching the farm and watching the statistics, the time to actually begin to gather the data to alert the responders can extend beyond 1 minute. We've seen as high as 5, 6, 7, 8 minutes take to process that. Well, if you're having a cardiac arrest, getting there in a minute and a half is probably impossible. So again, are you monitoring things from the point of the consumer or your citizen having the initiation of the event all the way through the process? If you're not looking at all of the data and constantly reviewing that, you're going to begin to fall into those situations. The other challenge that we've seen in a lot of communities is what traditionally, for instance, in downtown situations, it used to be at 5 o'clock, the sidewalks rolled up, you didn't have calls for service. Today, we've started to see downtowns become vibrant centers with a lot of people living there. That changes the whole complexity on when is EMS going to be needed in those areas. And just getting to the front door of, I always kind of remark that if I get to the front door of a 57-story building and the elevators are out and we have to get up to the 57th floor for a heart attack, about floor 7, you're going to have the second one, which is going to be me, because you've got the vertical distance. Not all cities are horizontal. We've seen that, for instance, in cities like Las Vegas that are largely horizontal. But you go to the casinos, and it can take a long time to get to the patient side. So strictly relying on just the response time to the front door is ignoring all of those other aspects. And but the challenge is sometimes getting the accurate information. Are you regularly monitoring all of those facets that make up the system? And then how long to get to patient side, how long to load the patient, how long are you being held in the emergency room? That's become a new kind of challenge for a lot of EMS systems, that it can be a long hold time that then deprives the community of those units being available and ready. So again, you have to look at this holistically and not just focus on one moment of time, because it could be giving you a very it could be giving you the wrong information by which you're going to make decisions of where to locate.
Yeah, and it's interesting when we here at MedStar went through our reprioritization, a lot of people always say, well, the patient expects, the patient expects. And what we found in doing a really deep dive into our patient experience survey data from the EMS survey team, one of the questions that the patients are asked is the timeliness of the ambulance arrival, and to evaluate that based on a Likert scale of 1 to 5, 5 being most satisfied, 1 being not very satisfied. And for ambulance only, no light and siren responses, we were still getting ratings of 4 and 5, even with a 45 or a 60-minute ambulance response time, because the patients knew they had a low acuity complaint. And the fact that someone came today to give them a ride to the emergency room or to evaluate them. So even the concept that the patients expect that, well, we set that expectation by and large, but if we're transparent with patients and really ask them, especially for the ones who know they have a relatively low acuity complaint, it's really, that's sort of a myth.
Yeah, that's always fascinated me, Matt, because I think that in medicine we've made a lot of, and I'm going to refer to what we do in EMS as medicine. We're healthcare clinicians who are taking medical care of people, and that is our mission. And in medicine we make lots of assumptions. We thought we knew which patients wanted antibiotics or which patients wanted various things. And when it was actually looked at, just about every time, what we find out is what we really thought the patients wanted is not the case. And so, I think this is a great example of that. You talked to a lot of EMS leaders and practitioners across the country. It's like, oh, the patients expect this. There'll be, there will be an uproar of, pitchforks and torches if we don't come in hot with lights and siren to everything that they've called for. And what they really want is somebody that is caring, that is professional, that has the healthcare knowledge and skills to help them with their issue. And and that goes to that other assumption that the patients all want to go to the hospital. What they really need many times is assistance in navigating the healthcare issue that they're having.
Yeah, absolutely.
And
Tom,
2 points. I mean, and that's why dispatch is so critical. If your dispatcher tells the patient, "I'll have someone right there," what is the expectation you've now established with your patient? Somebody is going to be right there. But if they're screening the call, going through the various checklists and everything, priority medical dispatch, and tell the patient, "I'll have someone there in 1 hour," knowing that you're going to be there in 45 minutes, does the patient think? This comes out of studies at Disney. If you ever go to Disney and they have the signs by the exhibit says it's going to be 45 minutes till you get to the front door, they know that unless a major incident happened, you're going to get there in 30 minutes. So they beat your expectation that they've set with that sign. And so when you get there in 35 minutes, you think, wow, these people are fantastic. So that's why the dispatch centers are so critical. There's also implications for ADA, a lot of things that start with the dispatch center, mental health crises. And so all of those factors are to look at. So if you're just looking at time, you're missing all of those other areas. And you can make some decisions that may or may not be good for the patient and the patient outcome. As Dr. Coop said, we saw during the pandemic as we were studying communities, a lot of patients didn't want to go to the emergency room. They were fearful of catching COVID, catching something else, and they just wouldn't call, period. And a lot of those then presented with much serious events, attacks, strokes, everything else. Exactly. And so we need to be cognizant of what is it our patients wanting. Are we surveying them after the fact? Are we following up? Are we making contact? All of those things really go into design.
Great. And I'm just looking at the chat real quick, and this will help, I think, with some of the dialogue. One of the comments in the chat was that, the NFPA sets a travel time standard, like they set a activation time standard and a call processing standard. 2 things about that. One, that's a voluntary standard, number 1. Number 2, that was developed many years ago. And I'm happy to report that the NFPA is working on a revision to 450 and 451 and the other standards. And that technical panel has, in many cases, drafted now for the EMS 455 standard recommendations very close to what Dr. Koop has referenced in that joint position statement, that response times are just one factor, and that current evidence and research and medical directors and all those things and communities need to set some of those expectations on their own. Balancing clinical need with realities and safety, all of those things. So you may see those standards changing, those recommended standards, those voluntary standards changing, but oftentimes standards that are broad aren't necessarily as nimble as some of the research that is being published on some of those, and that research is then used to revise the standard, which is great. So there's going to be a typical lag there. So thank you for that comment.
And Matt, I'm sort of watching the some of the stuff going by in the chat also, and encourage people to put things into the question and answer if you have questions that you want us to do. But it's easy for us to go down this rabbit hole of lights and siren, and this is all about so much more than lights and siren, which is just whether or not you save a couple of minutes on responses. It's the whole topic of today is much more than that. But I see some things like who will be responsible for creating the standards on when to use lights and siren and not. And honestly, I mean, some of this goes to the cities and counties and others that put out RFPs for EMS. And, the message is that, the RFP should not be based around how fast you get to every single call to 911. So that's one of the places where the standard is set. But the other place that standards need to be set are at the agency level, using the dispatch type of system that they have, and they vary. But some allow you to do it in one way, some allow you to do it in another way. But a lot of it comes down to working with an EMS agency medical director and the leadership of that EMS agency to look at your local data. Look at how many calls you go to for a motor vehicle crash with unknown injuries, and how many actually require care or even any transport. And you can just start picking away at things where your people know that responses to certain category things, seldom ever require significant care or even transport sometimes. Start picking away at the low-hanging fruit. But it has to be done with an EMS medical director and with leaders in the agency that are looking at the data.
So let's move.
Go ahead, I was just gonna finish up, Matt. One of the things that we're seeing cities challenged with, as our populations age, we're seeing a lot more lift assist. In many departments, those have become the majority of calls that they're responding to. And the challenge is, do you really need to get there in 4 minutes? If that person has medical attention already, they just really want to help getting them up, or they're worried about their liability, so they're looking at transferring to you as a community. Getting there very quickly is not going to be that critical. They could have a hip or bleeding, or have pains or stroke. Certainly, that's a different call. But we're seeing a lot of departments really be inundated, and it's becoming a challenge.
It is. And Dr. Kupis, let's move on to the next non-controversial topic, and that is having a paramedic on every response. And again, this goes back to system redesign. We have a paramedic maldistribution in this country. We've got a bunch of paramedics in urban areas. We've got limited paramedics in suburban and rural areas. But from a true clinical perspective, as an EMS medical director, as a researcher, is a paramedic necessary on every call? And should that really be the goal for some of these EMS systems, or is a mixture of advanced life support and basic life support, tiered deployment, safe and more reasonable?
Yeah, so great question. I think that when you look back, again, this is one of those things that we've sort of done to ourselves. You know, we developed an EMS system where it went from EMTs being sort of the baseline that responded to everything, and as communities developed paramedics, the paramedics would, you know, be assigned to higher level calls and in different kinds of response models. And then, you know, gradually it became, well, we should have a paramedic on every ambulance. Oh, we should have 2 paramedics on every ambulance. Oh, how about the first responder fire engine that gets there? That should have a paramedic too. And, you know, now, I mean, it's not even a paramedic on every call, Matt. In some places, it is, you know, 4 or 5 paramedics showing up in multiple vehicles on those lift assists on every single call, you know, all coming lights and siren, but I want to get away from the lights and siren stuff because that's not what it's really about here. And you're right. The healthcare has changed, right? People go to urgent cares instead of everybody going to an emergency department for their urgencies. People have evaluations at places where they have less resources, less high-end equipment, less things, because their condition doesn't need it, and it's more resource appropriate to get some people through healthcare systems into what they need in a better way. So why should we have continue to try to build this one size fits all? And I think that it's not as simple as ALS and BLS. You know, we use advanced EMTs and intermediate ALS response for some of our things too. So I mean, we have the high end things that need not only ALS, but you know, maybe even some additional sort of critical care paramedic type care that could be helpful in very high end things. We have ALS, we have intermediate ALS with AEMTs, we have BLS, and then, you know, if we really want to talk about system redesign, should an ambulance go to every 911 call? Maybe the lift assist is a better place for your fire first responders, and maybe the fire department going to lift assist, where you got a lot of guys with muscles and a vehicle that has more than just 2 people to help with a basic level assessment and a lift assist, and not even send an ambulance. Or in Canada, like they do, where they have some lift assist teams in some communities, where it's an EMT and a physical therapist that respond on the lift assist. And it's a very specialized lift assist team. So, you know, all of this plays into the fact that, yeah, no, we don't need 2 ambulances or 2 paramedics staffing every ambulance going to every one of these calls. We have to get the right resources to the right people at the right time.
And Tom, in your work with CPSM and local communities, are communities more open to that now? How has that come? How have some of your reports begun to infuse that debunking of that myth, if you will? And what's been the reception from a lot of these communities?
We're starting to see cities more willing to look at that. Obviously, since Seattle, King County, which always has been held up as kind of the place to go if you're going to have a heart attack, do not have a whole plethora of paramedics. Matter of fact, the communities, and there's been several studies out that show the communities with the fewest paramedics often have better outcomes. And the biggest reason, we actually demonstrated it in a department, a fairly progressive department, said, okay, let's see how often you can start an IV in a controlled setting in the station, and 50% of the time, the staff couldn't start a paramedic, or the paramedic couldn't start an IV. Couldn't start a paramedic either, but no, it became a challenge that suddenly, you know, under ideal conditions, it was hard to start IV. And the biggest problem was some of them had gone more than 185 days since they touched a patient when we look back at their time. You know, do you want to go to the heart surgeon that does a heart surgery every 250, 300 days, or maybe you're his first or her first patient? You want to be number 1 in the door. It's kind of like buying the new ladder truck or the new engine. You never want to buy the first model. You know, there are changes that go on, there are better things that happen, technology changes. So, you know, one of the things that we've seen in working with communities, they've really kind of badly employed more having the paramedic go out in a chase vehicle, do the triage on those serious cases. But what they're finding are those serious cases are few and far between. They're not that prevalent. And so if you're sending, you know, everything under the sun to a call, you're probably wasting a lot of resources. And again, are you triaging the call to begin with the dispatch? Are you sending, as Dr. Kuka says, the right resources to the right place at the right time? You go into an emergency room, you won't see 45 heart surgeons staffing the emergency room. You won't see an oncologist, and you won't even see anyone, a radiologist that's going to read your x-rays. They're probably going to do it from their home anymore, and they're going to do it digitally. And that's just the changes we've seen in medicine, that we've found we can do better or have better outcomes with better procedures and process. But yet we have not really transferred those down to the street level. I also know I'm old enough to remember when you had to be a paramedic to use an AED or
Well, you're really
stimulant.
dating yourself, Tom.
What's that?
You're really dating
Well, I was just
yourself.
watching Emergency last night, and they were using the paddles and everything else. You had to be a paramedic, go through extensive and be connected to the hospital. Today, you walk through most restaurants or through an airport, you'll see them about every 200 feet. You'll see an AED on the wall, and it's a matter of slapping the pads on, having I think it's a 1 hour or 2 hour first aid class. We've seen that what paramedics can do now can be done by people that aren't paramedics.
And
It's
Tom,
really
you're giving me some chest pain thinking of 45 heart surgeons or any other consultants hanging out in the ED. That would be a very stressful shift. But you use the idea of starting an IV, but I think the thing that probably concerns more people on what the example that you gave is, how do you keep every paramedic competent at doing things like advanced airway care and intubation and that sort of thing. And if you have them watered down where they're getting very little experience, you have a lot of people that are mediocre at that advanced airway care, but you don't really have a group of people that are really professional at that advanced airway care. And, I think that, that's just a sort of a side thing to this, because we're talking about finances, and part of it is the financial cost of having that many paramedics. But, all of these things that we're doing, how many vehicles you send, or what level of trained people are on those vehicles, et cetera, many times increases cost and actually decreases quality at the same time, which is the exact opposite of what we really want to do if we're going to run an efficient, value-added healthcare system in the pre-hospital setting.
And it limits resources, right? Because in our system, we ran an all ALS system until about 3 years ago, and our new hire academies would have generally about 8 people, because we could only hire 4 paramedics. And if you can only hire 4 paramedics, then you really only need 4 EMTs. So you have 8 people in your new hire academy. Well, now that we've gone to a tiered deployment model, and we're with a goal to get to almost half of our deployment being EMT level deployment, we're having new hire academies of 28 and 30 people, and they're all EMTs, and they're phenomenal EMTs. It's just, it's just really fascinating. And Tom, I remember there was a community in California, won't call out who it was, and we were helping them with some problems that they were having budgetarily in one of their agencies, and huge cost overruns and overtime and all sorts of things. And it was determined that a lot of it was the paramedic overtime and somebody bagging off, or a couple of folks calling in sick, and then you got to try and hire back paramedics on overtime or mandatory overtime them. And we asked for a simple piece of data. Could you give us all of the advanced life support care that was initiated by the first response department prior to the ambulance arriving at the scene of the call? And in 12 months of data analytics, there were exactly 0 where ALS care was administered by the first response agency before the ALS ambulance arrived on scene, or even at all if it was a BLS ambulance that arrived on scene. So as we really look at the system design, having an ALS resource available versus trying to put an ALS resource on every single response vehicle when 7% of the call volume requires a critical intervention that can only be administered by a paramedic is a reality that I think many communities are facing now. And I'm looking in the chat, one of the chat comments was that there are some agencies that require you to be a paramedic to be on the apparatus or to be on the ambulance, whatever. Well, we're seeing a lot of that change because there just aren't paramedics out there. And if you look at some of the national and some of the local news articles that have come out just this month, there are departments that were all ALS for a long time who've said, you know what, EMT is pretty good and advanced EMT is probably okay, but we might not even need the advanced EMT. But just to have a deployable resource to respond to calls, we're hiring bonuses, sign-on bonuses, department here, offering sign-on bonuses of $10,000. California, some of them are $20,000, $30,000, $40,000 sign-on bonus for when you really don't need as many. and again, we won't go down this rabbit hole, but I think Tom, he talked about the willingness, and Dr. Koopa said that really clinically, a lot of this comes down to dispatch. So a lot of it, and we saw some of this in the chat, and I'm getting text messages from people as well, that your dispatch agency and process, if you are not doing some type of emergency medical dispatch, APCO, MPDS, PowerPhone is out if that's still a thing. But if your agency is not getting that from your dispatch center, if you're not doing that as the dispatch center, I would argue that that's negligent. And having some ability.
It may be a violation of ADA laws. They're especially in the mental health arena. I've been talking with some folks at the Department of Justice, and there are some cases coming down where not having dispatchers that can begin to walk someone through mental health can be viewed as an ADA violation. You're not providing that service. But again, there's some other considerations beyond just even emergency mental health. And if you're looking at trying to get those calls out of just going to your police department, you need that information. But again, it starts with the call. Just if you go in the emergency room, you usually see a nurse or someone, a PA, who's going to triage you and say, okay, is this a serious call? And if it is, you go to door B, and if not, you go to the emergency room. And I know, having done that sometimes, that emergency room, you don't want to say, I want to go there, because it could be a long wait.
It could, absolutely. And again, I think a lot of this whole discussion is balancing needs with resources with the true needs, and honestly, just being straightforward with ourselves, that the things that we've believed for a long time and that we've sold our communities, new research, current research, probably isn't true. I had the opportunity to be in a session that my friend Colby Miller from MedStar Ambulance in Michigan, no relation to MedStar Mobile Healthcare, by the way, and he made the point, we don't carry mass trousers anymore. We don't carry draw spreaders anymore. We don't carry KED splints anymore. And we've dramatically changed how we do immobilization based on current studies and current research. And we are so quick and easy to change those types of clinical cares based on research that shows it doesn't help and in some cases may hurt. But when we look at the number of paramedics in the system, and we look at response times, and we look at light and siren responses, all of the studies show that many of those things don't matter, and in some cases cause more harm, but somehow we cling on to those things, and I'm not really understanding why, but that's a whole nother discussion. All right, Tom, let's go to you. CPSM obviously does a lot of work with ICMA members, and CPSM is getting a lot of requests now, certainly more in the last couple of years, on communities wanting to really look at their EMS and fire systems and that kind of thing. But what is really the number one issue that these communities are facing as it relates to their EMS system?
I think in smaller communities, it's the lack of or non-availability of EMTs, paramedics, anybody to staff their ambulances. A lot of the smaller communities we've worked in, for instance, New York State, still rely on volunteers to a great degree. And one of the challenges we've seen is who's going to take the place? Because when you go into some of those agencies, I remember one in particular, the average age was nearing 70 years old for the volunteers. People get tired. They do look at, kind of winding down. And so the big challenge there is, okay, who's going to take their place? And there isn't a line out the door waiting to fill those spots. And secondly, how are we going to pay for it? There are state laws, and for instance, in state, that if you're a volunteer agency, you can't bill. Obviously, there's no cost to sending an ambulance, so that makes perfect sense that you would have a prohibition on billing patients or their insurance companies. But we've seen those type of archaic laws that that affects a lot of local governments. I mean, are you able to bill what the cost of the system is? Are you willing to? There's also a tendency for some cities to say, if we don't bill the patient the full cost, the insurance companies will give them a better rate on. I can tell you that's a big fallacy. They're not going to carve out an exception for your community because you only bill them $100 an ambulance run. What they're going to do is pay you very quickly because they then can not pay you the rest that every other system. And we've seen that in California in a couple of cities, that they want to keep their rates artificially low, thinking the citizen will get a better deal on their insurance. That is never going to happen. that is not going to come through. What you're doing is transferring the cost of the system basically to the taxpayer and letting the insurance companies off. So that again is one problem. The other challenge is, how do we pay for this? The costs of getting people. You mentioned that we're seeing 5, 10, 20, $50,000 signing bonuses to get people to take positions. On top of that, we've seen salary increases, 10, 15, 20, 30%. All of that has kind of come instantly. And so it's really squeezed the system of how do we make this transition. For instance, I can tell you during the pandemic at the early stages, we were in Chicago area, and I went through the Burger King drive-up window, and at the time, they had a sign on the Burger King drive-up window, start here for $16.85 an hour. I went to the city, they were having a problem hiring paramedics, and I said, what do you start your paramedics at? $17 an hour. Now, there probably was a little bit of a disconnect that maybe you make more at a drive-up window at Burger King to get coffee than dealing with somebody's life and death situation. But all of those factors we've seen are really challenging cities of how are we going to provide the service in the future? And secondly, EMS is normally not a mandated service in most city charters and most state laws. So who's going to provide it? Who's going to pay for it? And it's always been kind of a catch can that, well, whoever didn't stand up in the room quick enough suddenly is in charge of that. But that's a real challenge. And then again, who's going to bill? Who's got the capacity? Who's got the capability to bill? Who's got the HR department to do all the backgrounds? I mean, it's a complex system. And then throw in that you can't even get the boxes for 1 or 2 years to transport people. That you were looking at, extended delivery times. I was just talking to a city manager in Florida, and he said, "Have you heard that it's taken you 2.5 to 3 years?" I said, "Yes," and that's what they were looking at.
Yep, absolutely. And I do want to make a quick comment to Brandy. We are essential, but we just
Yes.
haven't been designated that by a lot
Exactly.
of states, primarily because many of the lawmakers don't want to make it a requirement to have to fund it now. And that means more taxes, and that means you lose your seat in the city council and all sorts of that kind of stuff. So it's interesting conundrum. Dr. Kupas, same question to you.
Yeah, absolutely. And we have some great questions coming in on the question and answer too. I'm hoping we can get to those. So here's how I would answer this question. Number one systems issue for local communities. I think the number one issue is balancing appropriate balance of resources to patient needs. And I think that, many communities look at this too simplistically and look at it like, well, we don't have enough people, we don't have enough stations, we don't have enough vehicles because we're getting, too much call volume to get to everybody in our expected time, et cetera. But I think that the number one issue is that communities really need to take a different look at this, and it's balancing what the patients need from a medical healthcare condition with the resources that you're sending. And then I would say, if you ask me as just purely from the clinical patient need perspective, I would reiterate the issue of the epidemic of falls in the elderly. I think that every EMS system is being inundated with this. I had a medical student riding along with me in the field yesterday, and he was telling me last month he was on his trauma rotation. And when he did every single shift that he did on trauma, for him, it just happened that every single patient that he saw for trauma was an elderly fall victim. It's a medical student, just did a week of trauma surgery, and it used to be motor vehicle crashes, and if you're in an urban area, shootings, stabbings. We still have those, but the number one admission for falls at trauma centers in Pennsylvania at every level, urban, rural, et cetera, is falls in the elderly. So I mean, we have this epidemic, and I think when you say number one system issue, if your system is not putting a lot of effort into how you take care of the little falls and the big falls, but primarily those little falls and the lift assists and things, you're going to be in big trouble because you just can't handle them all the way you did 10, 20, 30 years ago with our paradigm of EMS.
Great comment. I want to take a couple of questions that have come in on the Q&A chat or on the Q&A box before we wrap up with a couple of final pieces of advice. But Chris Hansen, always being the insightful healthcare leader from TMF and others, he said the U.S. healthcare system differs greatly from other developed nations in many ways. How do the pre-hospital systems in other developed nations treat pre-hospital triage and response times? And I would argue, I'm going to throw tiered response in there. For those of you that are on our email list, we just sent out an email this morning about a community in Prince Edward Island, Canada. And Canada, by the way, Canada is light years ahead of the US in terms of EMS system development and effectiveness. And they just put a community paramedic unit in service on Prince Edward Island that's going to go on all the low acuity calls. And they're going to use that community paramedic unit to triage patients that get an ambulance, and the ambulance crew determines based on the medical director's criteria that this patient does not need to be transported to the emergency room. We're going to do the referral to the community paramedic unit, who will be here sometime today to do a further assessment and get you referred to wherever it is that you need to go. In the UK, where they've got a universal health system, their entire process, and Chris, you probably know this and you set up this question well, their 999 center has a plethora of resources that they can deploy based on the nature of that patient's call to 999. Nurses in the communication center that triage a lot of those patients. Their goal, I believe, if I remember, Tom and Dr. Kupas, is that they only want to respond an actual ambulance to 49% of their 999 calls. They want to handle the rest of them without having to send an ambulance. They have physicians in the field. They've got paramedics who are licensed to do, treat, and refer, to not bring patients to the emergency department because they've got a single budget that all of that is paid from, and they know that clinically, most patients don't need an emergency department. They just need to see if they, can get referred to their whatever. But Chris, you're spot on. A lot of other countries handle EMS much differently, and the goal is to navigate patients, not just require that they all go to the emergency room unless the patient stops you from taking them to the emergency department.
To follow up, Matt, just wanted to follow up on that. The big challenge with our systems is normally if you didn't transport, you can't charge or you can't bill. And that drives a lot of our decision making, that, well, we have to load the patient. Whatever we got to do, we got to get that transport because that's the only way we can recover our costs. And that begins to dilute all of a lot of the other decisions we could make that would be better economics, better for the patient, and have probably better outcomes. Because the only way we can bill is to take that person in the back.
And shorten cycle times for task times for the units, 'cause especially if you've got ER delay issues, which increases resources in the community at no cost to the community. And that, I think, Tom, ties right into one of the most recent questions that came in from Jonathan, where he talks about how do we get the ET3 model to be reinstated and supported by CMS. It's never going to happen. However, the good news is that there are currently one introduced bill in both the House and the Senate, and one pending in the House that reimburses EMS for the response, not the transport. And we, as many of you may know, we just got, after 2 Freedom of Information Act requests to CMS, NAEMT just got the data from the ET3 model that shows hundreds of millions of dollars in savings to the healthcare system if EMS's payment model was changed to reimburse for non-transport. So those bills have huge support in Congress. As some of you may know, I and Dr. Rock had an opportunity to testify before the House Ways and Means Committee on this issue in March. They've followed up, and the chairman of the House Ways and Means Committee, which is one of the committees of jurisdiction over the payment reform for EMS, very interested in this, and they are moving bills through Congress to essentially change the reimbursement model. So we don't have to do ET3, we just get reimbursed for non-transport. Many state Medicaid agencies are doing it, commercial insurers are starting to do it. So I think we're going to be seeing that on a much more normal basis, if you will. And then I think to answer Joseph's question, Dr. Kubis, I'll turf this to you. Do you know of any studies, and I think you may have talked about this, that break down that 7% of high acuity responses into responses versus transports? In other words, what percentage of the 7 are actually transported as high acuity patients? Do you have any insight into that at all?
Yeah, so I saw that question. That one is interesting. Even before you started talking about London and that sort of thing, and 50%. I mean, it is absolutely clear that in just about probably every EMS system, you can safely not transport 30 to 40% of your patients, and in some cases, it's probably 50% or even more if you. And the higher end of that is if you also have things in place to help take care of those people's needs without transport. The specifics of Joseph's question here is talking about that study that shows that 7% get some potentially life-sustaining treatment. And I think that it's probably safe to say that nearly 100% of the patients that get one of those potentially life-sustaining treatments do get transport. Although we know that there's exceptions to everything, right? There are the people that get naloxone and they were near dead, and now they wake up and walk down the street and refuse treatment. So, it's not 100%, but most of those. But I mean, that's not really where you're going to shave off the big value in EMS. It's more in these other things. I do want to echo what you said about the treat in place laws. I am very, very hopeful that that treat in place does happen, and that everybody is able to do something that is a little bit like what ET3 was. My agency is one of the few that was in ET3, and we've got all sorts of great outcomes for patients. That everything from taking patients that call 911 for distress and leading to a hospice enrollment without being transported to the hospital, to more simplistic things like taking care of the person whose blood pressure reading was high and they called 911. Somebody whose blood pressure reading is high and they call 911 and they have no other symptoms. Those virtually none of those people benefit by going to an emergency department. But there are lots of examples of patients that we can help take care of and navigate into appropriate care without that. As a physician, though, and I need to, and an EMS physician and medical director, we have to stress the importance of, as we start doing more of this, and as you get more and more innovative in who you leave at home, it is absolutely critical that there is very close physician oversight of these programs and also other parts of the system of EMS professionals doing quality improvement, et cetera, to make sure that you're doing these things safely.
Yeah, the last thing we want to do is to start stacking bodies like cordwood at City Hall, because then all these innovations go away, right? If they're not medically appropriate, supervised, QA'd by a really strong medical director.
And one other really quick thing, it's easy to give up and say, well, we only get paid for transport, so right now we're going to tell our people transport everybody. That I think is a very short-sighted way of doing it, because if you do have those patients that clearly aren't going to benefit by transport, it does get your unit back in service quicker. In North Carolina, in Charlotte, they had started with their multi-tier triage now, and some having longer waits. They've started having some of the callers just sent an Uber to take them to the hospital, and the ambulance agency is paying for it. And you would say financially that makes no sense. Not only are they not getting paid for the transport, they're like paying for a small percentage of their patients that they're actually sending by Uber. But when they run the numbers, it is cheaper to do that than it is to buy more ambulances and have more out there, and potentially miss calls for somebody with a life-threatening thing because you're using your resources in a poor way. So communities should not just say, well, until we get paid for all of this, we're just going to transport everybody. That's the only way we get paid. That is a bit of a scapegoat, I think, and a way to look at it that isn't the most appropriate for your community, your agency, or the patient.
All right, for each of you guys, one sentence, because Melissa's got to wrap up. And Melissa, before I forget, a quick programming note. Can you please make sure to download the chat? Because we can respond to some of these questions in a paper and a publication that we put out to the attendees and others. But we'll start with Tom. Tom, one sentence, one piece of advice for local elected officials and EMS leaders on redesigning their EMS delivery.
Make sure that you have good data, and make sure that you've involved your medical professional. It's a team approach. If you drop one piece out, you're going to probably.
And Dr. Kupis, same question to you.
I think my one piece of advice would be for those community leaders: start by realizing that EMS clinicians are healthcare professionals, and they can add great value to the health of your community if they are able to use their full resources in ways that are most appropriate.
Great. Well, I want to thank Dr. Kupis, and we did some of the questions already, but thank Dr. Kupis and Tom for their time, effort, and certainly their expertise in providing some of this. I'm going to turn the virtual floor, over to Melissa, who's going to give you some exit instructions.
Thank you, Matt. We appreciate your attendance for today's webinar. A recording of today's webinar will be posted on the NAEMT website within a week or so. To view, visit the NAEMT.org and click the events tab, then EMS webinars and podcasts. Replies to unanswered questions will be posted along with the recording on the NAEMT website. All participants will be offered a pop-up evaluation after the conclusion of today's webinar. We value your feedback and suggestions. NAEMT is proud to host a repository of recorded webinars on demand for NAEMT web members. To view topics and assess the recordings, please visit the NAEMT website and click on Events, Webinars, and Podcasts. We hope you will join us for future webinars or check out our podcast on NAEMT Radio, offered through a variety of platforms. For more information about NAEMT and our programs, initiatives, and activities, visit our website at www.naemt.org or go to your resources section and you can click from there. The EMS profession looks forward to celebrating the 50th anniversary of EMS Week. This year, as we recognize the 50th anniversary of the first National EMS Week, we honor those who came before us, especially those who challenged the status quo and raised the bar for all of us. At the same time, we look forward, building on their efforts and committing ourselves to forge a future for the next generation of EMS professionals to serve their communities. Visit the emsweek.org site to obtain resources for celebrating EMS Week, May 19th through the 25th. Thank you, everybody. Please remain healthy and stay safe, and we appreciate your attendance today.
Thanks, you guys.